So we are good to start. So with all your
Yeah.
due permission, we are beginning with the session for today. Good evening, everyone. This is Batul from IGCP, the moderator for today's session. And I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, who is present here with us today. And he's none other than Dr. P. Karthikeyan sir. Sir is MD in Internal Medicine, DM and Gastromedical Gastroenterologist at Royal Care Super Specialty Hospital Limited at Coimbatore. With such wonderful insights, we are going to talk about the topic for today, which is non alcoholic fatty liver disease. So, now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So, over to you.
Oh, thank you. Thank you very much. Thank you. It's nice that we are meeting on a scientific forum so that I can share some insight on some of the burning issues in gastroenterology and the overall well-being of human society. So I thank you for the forum for giving me this opportunity. Hope we'll be having many more kind of interactions. And if you have any suggestion to make or some questions or something, you can post them in the chat box or something. Probably it will be directed to me, and I'll try to answer it towards end. So, what are the learning objectives today? It is about the non-alcoholic fatty liver disease, which is quite common now, and we have seen over the past 10 years. So, I've been practicing gastroenterology for the past 20 years, and over 10 years, last 10 years, we have seen exponential increase in non-alcoholic fatty liver disease among general population and as well as some of the patients that we see, the gastroenterologists see. So it has become the number one disease in GIOP, gastroenterology specialist OP, number one case in hepatology clinics, as well as number one cause for liver transplantation nowadays in the Western world. So this is increasing at the alarming rate, just as the non-communicable diseases are happening in India and rest of the developing countries. This is what we had previously in the US and Europe some 2, 3 decades ago, and now we are following suit with the Western world. So what we can do now, this progresses, and what we can do to reduce or curtail the effects of non-alcoholic fatty liver disease is the main agenda of today's talk. So we'll be learning about the epidemiology of non-alcoholic fatty liver disease, the simple pathophysiology of NAFLD, how to diagnose NAFLD in a community setting, in a primary care setting, and a brief account of the treatment and management part of NAFLD. Next slide, please. Epidemiologically, we have seen that this is the most prevalent cause of liver disease in the developed world, and soon it will be happening in India also. The most common disease of liver in the developing countries as well as NAFLD. Previously, we used to have viral hepatitis, hepatitis B, hepatitis C, and alcoholic hepatitis competing with the number one spot along with NAFLD. And now NAFLD is the number one disease affecting the liver in our population as well as the developing countries. It is primarily because of obesity, which is rampant here, the prevalence of the underlying diseases like obesity, hypertension, metabolic syndromes, people who are on drugs, sedentary lifestyles, etc. We have seen that it is almost 25% of world population is in AFLD. And in the South America, which is again a developing country like us, Middle East, it is about 30%. North Africa, which is impoverished compared to the Western world, the incidence is lower. 30% of US population has obesity as well as NAFLD. In India, the estimate is around 30% in urban and 24% in the rural population. The rural is slowly catching up. We have seen the latest NASCOM study also that rural spending and the rural economy is all slowly catching up with the urban one. So It is not surprising if NAFLD prevalence is also catching up with the urban population. It is the second most common cause of end-stage liver disease and the need for transplantation in the US, second only to alcoholic liver disease. And it is still the same with India also. The viral hepatitis will almost be eradicated. Hepatitis C. Hepatitis B, the incidence is about 7% at the maximum, whereas the NAFLD incidence is about 20-25% in a liver transplant center. This is predicted to become the number one indicator for liver transplantation next decade. Almost it has come. It is the third most common cause of hepatocellular carcinoma in the US. Next slide, please.
So you are in mute and you cannot be seen as well. Would you
I'm
please
sorry.
turn?
Yeah,
Yeah,
yeah, I had a call. Yeah.
yeah,
I
yeah.
just, okay. Yeah, we are back. Okay. So suppose if there is a population, then each 4 to 5% of yeah. So we have 20 to 25% of the entire crowd has obesity, and out of which 20 to 25 has NAFLD, non-alcoholic fatty liver disease. They have fat accumulation in the liver without any inflammation. This is what we call as NAFLD. And those are people who have metabolic risk factors like type 2 diabetes mellitus, obesity, unhealthy diet, sedentary lifestyle, genetic polymorphism in terms of PNPLA3, etc. These people are prone to develop fatty infiltration inside the liver with or without inflammation. Out of which 10 to 20% of them will have inflammation associated with that, which we call as NASH, that is non-alcoholic steatohepatitis. Out of which, over a period of 10 years, 30% of them develop cirrhosis. This is alarming. So 25% of obesity have NAFLD, and 20% of them develop to have progressive disease like NASH, non-alcoholic steatohepatitis, associated with fatty and inflammation, out of which 30% develop cirrhosis, and out of which 0.5 to 4% will have hepatocellular carcinoma. And these are the population. When consider the India's population, which is very huge, the incidence of cirrhosis and hepatocellular carcinoma is also huge. Okay, so in another decade or so, we'll have a huge surge of liver cirrhosis and hepatocellular carcinoma secondary to NAFLD. So our healthcare setup should always keep that into mind, and to have an infrastructure enough to handle such a kind of epidemic, which is coming out of proportion to what we usually see. Next slide, please. So almost 90% of people who are morbidly obese for bariatric surgery clinics have NAFLD. People who have diabetic mellitus, almost 60% will have NAFLD. People who have metabolic syndromes, obesity, hypertriglyceridemia, hypertension, increased waist circumference have 53% prevalence. Dyslipidemia, 50%. Male gender, it is twice that of the females. And ethnicity of Hispanic and Asian have 50% prevalence of development of NAFLD. Next slide, please. So considering the fatty deposit in the abdomen, it is more of the visceral fat that contributes to insulin resistance and NAFLD. If it is subcutaneous fat, it is not very much concerned with the NAFLD. If it is a retroperitoneal fat, it is still not a high risk factor. But if it is a visceral fat, that is fat around the organs like kidneys, pancreas, spleen, etc., these momentum and peritoneal fat, these fat is a high risk factor for NAFLD. So that is why you don't get NAFLD in this sumo wrestlers in Japan who are extremely obese but still may not have NAFLD. But those people, especially the Indians who have apple kind of body habitus, have more of visceral fat than the subcutaneous fat and are highly prone for non-alcoholic fatty liver disease. Next slide, please. Coming to the pathogenesis of fatty liver, liver has no fat inside it. So that is the dictum. You don't get liver cells laden with fat. If there is a fat accumulation in the liver, it is abnormal. Either there is an increased surge of free fatty acid into the liver, or the liver is not able to metabolize the free fatty acid into triglycerides or VLDL or LDL and eliminate it through the bile acids. So both any one of the problem or both combined may be a harbinger of fatty liver disease. Coming to the free fatty acid surge into the liver, it is primarily because of the visceral adipose tissue, which is the which is the predominant provider of free fatty acid into the blood. The adipose tissue get lipolyzed and free fatty acid is released into the blood, from which the liver absorbs the free fatty acids inside the liver. Usually by normal mechanism, the free fatty acid enters the acetylcholine enzyme and will take part in the tricyclic cycle and will come out as a gluconeogenesis or into the citric acid cycle for energy metabolism. If that is a problem, if there is a problem in the energy metabolism or acetylcholine esterase formation, then there is the accumulation of free fatty acids or triglycerides inside the liver. This is harmful for the liver in long process and may cause inflammation around the fat lobule, which in turns give rise to inflammation and fibrosis. The second possibility is the insulin resistance, which is the primary cause, which prevents the free fatty acid from getting metabolized. Okay, that is the second mechanism. This gives rise to increased triglycerides inside the liver, and there is a paucity of elimination of triglycerides in the form of VLDL or LDL. This could happen because of insulin resistance. Because of high dietary sugars like fructose or glucose, there is a high influx of triglycerides and free fatty acids into the liver, which soon get metabolized to triglycerides and stay inside the liver without getting eliminated. Next slide, please. Yeah. This accumulation of liver fat give rise to hepatocellular injury and may give rise to signals inside the liver for other reactive oxidant species, ROS, lipotoxic stress species cascade like interleukin 6, interleukin 1, interleukin 12, etc. And there is a mitochondrial dysfunction and gut dysbiosis, increase in tumor necrosis factor, transforming growth factor beta, etc., which often stimulates the hepatic stellate cells to lay fibrosis on the hepatocellular canaliculi. And this fibrosis progresses to form cirrhosis. And the fibrosis independently is a risk factor for hepatocellular carcinoma. Next slide, please. So this is the mechanism for non-alcoholic fatty liver disease, progresses to NASH and cirrhosis. Primarily, there is insulin resistance. Primarily, there is increased lipolysis and increased influx of free fatty acid. And inside the liver, there is a paucity of triglyceride getting eliminated. All this combined forms the inflammation, deposition of fatty lobules, which in turn give rise to inflammation and deposition of fibrosis because of the activation of hepatic stellate cells. How to diagnose NAFLD? Most often, the people may be unaware of the underlying fatty liver disease. Some people may have vague abdominal discomfort in the right upper quadrant. When we examine the patient, these patients may have a soft liver that is palpable below the right costal margin. On ultrasound is a very sensitive test for diagnosis of fatty liver. May not be specific. It gives a bright echogenicity on ultrasonogram. This brighter than the spleen. So when when the liver is brighter than the spleen, we call them there is a echogenicity, and the fat deposit is more than 30%. The sensitivity is high when the fat deposit is more than 30%, for which we call them fatty liver. Fatty liver. But this is not very specific. So we need other imaging facilities to diagnose and confirm fatty acid. Excellent sensitivity can be arrived with MRI, either with MRI PDF or a plain MRI abdomen. that gives a good estimate of amount of fat present in the liver. We can quantify the fat from which we can have a good amount of data from MRI liver for fatty acid. Liver function test usually will be normal in early cases, may not be very specific, so we don't rely upon liver function test to assess the severity of fat liver. 30 to 60% of people will have normal ALT, but sometimes ALT may be mildly elevated, like 40, 45. Remember, the normal value of AST and ALT are not 40 and 45. It has been reduced now to 20. So 19 for AST and 20 for ALT in both the sexes, males and females. So anything above 25 in both the sexes are abnormal, and fatty liver is the commonest abnormality associated with increased AST and ALT. Alcoholic liver disease, drug-induced liver disease, all can have a spurious elevation of AST and ALT. So it needs to be rechecked after 4 weeks of stopping any drug to reconfirm elevation of ALT and AST. Suppose the patient has increased AST and have high risk factors like metabolic syndrome, type 2 diabetes mellitus, obesity, hypertriglyceridemia, increased weight circumference, family history, etc. So we go on establishing a diagnosis of free fatty acid with a variety of tests nowadays called as the non-invasive testing, NIT. This is called as non-invasive testing, the diagnosis of fatty liver disease. What do you mean by non-invasive tests? These are blood tests that have composite scores that take into account of multiple parameters like age, BMI, hyperglycemia, platelet count, albumin, AST, ALT ratios, hyaluronic acid, other IL interleukins, etc. Some of the proprietary composite scores take into a number of parameters into account and have a composite kind of score which can be interpreted very easily. Most of the scores are free for use. We can just log on to the website and input various parameters and they give results as in numbers. This can be easily done in an outpatient setting, even with a primary care physician or a physician assistant can easily do it. So one of the tests is called as NASH fibrosis score, NASH fibrosis score, or the FIB score, FIB score, which is non-proprietary. That is, we don't have to pay for it. It is free of cost. We can get it done online. So we have to input certain data and we can get the result. So if the score is if the score is less than 1.4, then the patient doesn't have any fatty liver with advanced fibrosis. Remember, these scores will detect the amount of fibrosis present in the liver, not the amount of fat, not the amount of the amount of fibrosis that is taken into account while uh, while interpreting the scores. Okay, if the NFS score is less than 1.4, we can conveniently rule out advanced fibrosis in these patients with a sensitivity of 93%. The negative predictive value of NFS score is 93% in ruling out significant fibrosis in a fatty liver. Okay, we can counsel them with lifestyle modification. We can reassess them once in 2 to 3 years. Okay. If the NFS score is more than 0.6, less than 1.4, we can say that the patient has advanced fibrosis with a confidence of 90%. So these patients have to be referred to hepatologist for further care, including fibroscans, biopsies, and etc. What if they fall intermediately between minus 1.4 to 0.6? They are called as the indeterminate range, and these people should be followed up every 6 months with the same score. If the score is progressing, refer them to the pathologist. Sometimes these people may need additional testing like fibroscan or biopsy or ELF score to categorize them either into NFS positive or NFS negative. Okay, so the simple test is FIB score or NFS score, which can be done. With NFS score less than minus 1.4, virtually rules out advanced fibrosis.
NF score more than 0.6 virtually tells that this patient has advanced fibrosis, high risk for progression to cirrhosis. Intermediate, we have to follow them very closely. Next slide, please. Yeah, this is called as FibroScan, which is a proprietary by GE people, and they have devised an equipment where they pass the sound waves into the liver, and the speed at which the liver, the sound wave travels the liver gives a rough estimate on the stiffness of the liver. The stiffness is proportional to the fibrosis. Okay. The stiffer the liver is, the faster the sound progresses. We know the sound progresses fastest in the solids, faster in liquids, and slow in the gaseous medium. So this has been taken into advantage for us. If the sound waves traverses very fast inside the liver tissue, it means the liver is stiff and there is advanced fibrosis inside it. So we can measure it with multiple um, multiple shots inside the liver. So we can averagely we used to do 10 to 15 shots. So we can have um, a average of the resultant parameters, which we call as the transient elastographic measure. The stiffness is taken as kilopascal per meter square, and the optimal score is usually 3 to 4. If the score is beyond 8, we think that the patient has significant fibrosis. If it is beyond 12, we can think that the patient is almost cirrhotic. We have to do all the tests necessary to confirm the cirrhotic nature of the liver. Okay, there are a lot of parameters tend to um, um, confuse our estimated the FibroScan score. One is obesity with high subcutaneous fat. Other is ascites. Ascites people, the resultant of the FibroScan may be misleading the height. People with cardiac failure, people who are obese, people who underwent surgery in the upper abdomen, all have different values, which has to be interpreted with caution. We have different probes for these people so that we can get a universal values for even these people. The optimal liver stiffness cutoff for advanced fibrosis is 9.9. We used to take it as 8, which is 95% sensitivity and 77 specificity for advanced fibrosis. The FibroScan, as we told, is fastly related with active inflammation, viral hepatitis because of the fluid inside the liver. The fibros score is usually high. Significant steatosis, hepatic congestion because of the congestive cardiac failure, acute alcohol intoxication people also tend to have increased fibroscore, which may have to be retested after abstinence of 2 weeks. Next slide, please. So second option is a gold standard is a liver biopsy. We rarely used to do liver biopsy to confirm the presence of fatty liver because it is clearly evident with FibroScan, ultrasound, or MRI. Sometimes if there is 2 or 3 problems coexisting, whether the patient is drinking alcohol and now has a fatty liver, which is because of metabolic abnormality, when there is a confusion in the contribution of alcohol versus metabolic, we can do a liver biopsy. If the patient has coexisting viral hepatitis or drug-induced liver disease, we used to do biopsies. Okay, liver biopsy, there is a standard score called as NASH activity score, which grades necroinflammatory activity in terms of steatosis, ballooning, and lobular inflammation, and fibrosis score from F0 to F1. F0 is no fibrosis, F1, F2, F3 are fibrosis, and F4 is cirrhosis. Next slide, please. So this is the liver biopsy finding. Normally, there may not be any fat globule in the liver. If at all, there is less than 5%. If the steatosis is more than 5%, we call them NAFLD. If there is an inflammation consisting of neutrophils, lymphocytes, etc., around the lipid droplets inside the hepatocytes, so we can call them the mononuclear inflammatory infiltrate, which is usually perivenular, which may extend up to the central venous or the entire lobule may be involved, which is called as the lobular inflammation. and ballooning degeneration of hepatocytes can be noticed. The hepatocytes usually be enlarged with pinkish and pycnotic nuclei with variable degrees of fibrosis. This is the usual typical characteristic of NAFLD. Next slide, please. So coming to the management, we have lifestyle modification, treatment of metabolic syndrome, and liver-directed treatment. So all these things should be combined and should have a holistic approach towards management of fatty liver disease. So the patient is usually heterogeneous. There may be patient who are obese, overweight, versus lean and fluctuating BMI. There may be patients with diabetes or non-diabetes. There may be people with insulin responsive diabetes or insulin resistant diabetes associated with metabolic syndrome. There may be people with physically active or sedentary lifestyle, drinking alcohol versus abstinent, young versus aged, and with comorbidities affecting heart, lungs, and kidneys. Also, there will be liver who have simple steatosis, NASH without fibrosis with inflammation, NASH with early fibrosis and inflammation, NASH with significant fibrosis, advanced fibrosis, or cirrhosis, or with hepatocellular carcinoma. So each patient has to be tailor-made and should be approached in the best possible conditions and should have counseling and goal-directed therapy in these people. Next slide, please. Dietary recommendation. Next slide. Yeah. So one has to avoid taking high sugar diets, including the beverages, including fruit beverages, tinned beverages, etc. And the reduction of the overall energy demand should be around 750 to 1000 kilocalories per day. There should be less of saturated fats and fatty acids, trans fats. Avoid fast food restaurants, cookies, etc., which raises the sugar and the free fatty acids rapidly. Soft drinks, containing simple sugars, including fructose and glucose, should be avoided. Alcohol consumption should be avoided if possible, or should be in moderation. More than 3 cups of coffee. Coffee is protective, hepatoprotective. So 3 cups of coffee. Coffee, as I told, is without milk and should be without sugar. And one can have 3 to 5 cups of coffee, which is hepatoprotective. Mediterranean low-caloric diet is highly recommended if the people is able to take it. Next slide, please. So weight loss is a central option in NAFLD management. The amount of weight loss corresponds to the amount of improvement in the liver. When there is a 3 to 5 percent of weight loss, there is a reversal of hepatic steatosis. The fat in the liver comes out, and there is a reduction of minimum 3 to 5% weight loss, and there is a 5 to 7% weight loss. There is a decrease in the inflammation as well as hepatic steatosis. When there is more than 10% weight loss, there is an improvement in hepatic fibrosis as well. So always aim at 10% weight loss in any patients who are on advanced fibrosis. Next slide, please. So this is a general recommendation by various society, including ASL, NICE guidelines, Asia Pacific study of liver disease, etc., ASLD, etc. There should be a calorie deficit of 500,000 kilocalorie per day, weight loss of 7 to 10% with dietary as well as the energy expenditure, low to moderate fat, moderate to high carbohydrate, high protein diet should be advocated, and Mediterranean diet is the best option. So the NICE guidelines also says the reduction of 600 kilocalories, low calorie, low fat diet. Physical activity, at least 3 to 5 sessions per week with at least 150 to 200 minutes per week training, either aerobic or resistant training. Resistant training, what I told is weightlifting kind of stuff, or aerobic is the best form of exercise, or at least 30 minutes of moderate or heavy intensity physical activity like running, jogging, swimming, cycling, etc. at least 5 days a week. Next slide, please. So improved activity increases the peripheral insulin sensitivity, decreases hepatic de novo lipogenesis, decrease liver triglyceride production, and decrease storage of fat inside the liver. There is a reduction in the visceral fat, reduction in the lipid delivery to the liver, which increases the hepatic VLDL clearance so that none of the fat remains inside the liver. Vigorous activity in NAFLD, at least 75 minutes weight of per week activity, reduces the risk of NASH. When there is more than 150 minutes, we have reduced risk of advanced fibrosis. Further enhancement in the physical activity doesn't really correlate with the amount of fibrosis reduction. So maximum we can allow them 150 minutes per week vigorous exercise. Aerobic versus anaerobic resistant training, both are equal in reducing the hepatic fat independent of weight loss. Next slide. So next step in the management of NAFLD is screen for worsening of metabolic diseases and treat if indicated. People who have dyslipidemia always measure the triglycerides every 3 months and make sure that it is less than 100. Make sure that the patient is normotensive with medications if necessary. Ideally, ACE inhibitors, ACE blockers, or beta blockers are ideal choices for NAFLD-related metabolic abnormalities and hypertension. Type 2 diabetes, make sure that the patient is well controlled and the HbA1c is less than 7. Monitor liver chemistry once in 3 months. There is a liver-directed therapy. There is no proven benefit of any liver medicines in improving fat liver, but still we got some medicines which I come to it a little later. Comorbidities has to be treated like cardiac failure, respiratory failure, obesity, sleep apnea syndrome, etc. Statins, when given, are safe in patients in AFLD, particularly in a conventional doses like 10 to 40 milligrams. Lifestyle intervention to achieve weight loss should always be the first step in the treatment of NAFLD. Cultural bariatric surgery if patient is unable to lose weight and they are morbidly obese. Next slide. Next slide. Next slide. Yeah, there is a comparison between Mediterranean low carbohydrate diet and low fat diet with respect to the MRI findings. We can see that Mediterranean low carbohydrate diet reduces a significant amount of fat within a period of 6 months. When there is 27% of fat is reduced to 5% after Mediterranean low carbohydrate diet for 6 months, whereas a low fat diet reduces only by 6%. 6%. So ideally, best option is a Mediterranean low carbohydrate, low fat diet versus the low fat diet of the Asian protocol. Next slide, please. So how to reduce weight? So people with 52 weeks intervention of physical activity and calorie restricted diet, 30% of them lost 5% of weight, 58% had resolution of NASH, and 82% had 2-point reduction in a NASH in the NASH activity score by histopathology. About 10% of patients lost more than 10% of weight loss, and 100% had reduction in NASH activity score. 90% had resolution of NASH, and 40% had regression of fibrosis. It reiterates the point that weight loss is central to management of NAFLD. Next slide. The problem with weight loss is the sustenance of weight loss after 1 year. Most of the people will get back the weight once their calorie restriction is gone. So one has to have a continuous motivation and social support to continue losing weight or to maintain weight and the 10% reduction level. Next slide. Yeah, okay. So this is what I was telling previously. 10% weight loss reduces fibrosis, 7% reduces NASH, 5% reduces the ballooning degeneration, and 3%, 2 to 3% reduces steatosis. Next slide, please. So all these things should be taken care of while getting the history of compulsive eating, history of addictive eating disorder like bulimia, etc. Night eating syndromes, binge eating or depressive syndromes, all should be carefully sought out because most of the time patient may be unaware of such a kind of practice. One has to bring it to the limelight and should offer them support and psychological advice to avoid compulsive eating in these categories. Dietary herbal supplements are usually unusual and sometimes harmful, and it should not be a factor um, uh, without lifestyle modification to achieve a shortcut to reduce weight. So these may be harmful. Sometimes it may affect the liver or the kidneys. So our population always seem to have a short-term shortcut to have benefit. So it is not working. Always aim at weight loss to improve your metabolic profile. So treatment of diabetes when combined with NAFLD, usually metformin is a standard of care. Metformin decreases the HbA1c when given alone or with pioglitazone or GLP receptor antagonist or SLGT inhibitor. Hypertension treated with AC inhibitors, and hyperlipidemia is treated with statins. Next slide, please. These are some of the drugs that we use for diabetic are also useful for fatty liver disease. Metformin, GLP analogs. Still, it is insufficient and maybe potentially useful as far as the EAC guideline. Vitamin E, there is not much of evidence. PPAR gamma can be considered useful in diabetic patients. Obeticholic acid, there is little evidence in controlling NAFLD. Next slide. Liver specific protectives like UDCA, Silimarin, etc. as an adjuvant and treatment, not very useful in people with advanced fibrosis. Next. These are some of the drugs, next slide, that we used to use. Antioxidants and vitamin E. Now it is almost not useful. It is not the algorithm. Insulin sensitizers, pioglitazone can be used in diabetic people with NAFLD. Metformin, GLP analogs like liraglutide or semaglutide can be used to control the sugars. Empagliflozin increases the hepatic lipogenesis and reduces the liver fat as well as the necroinflammation, but not the fibrosis. Statins can be given. FXR antagonist obeticholisis not much useful. Next slide, please. In pediatric people, it is very difficult because much of the genetic contribution is very high. PPA, PPL3 genetic polymorphism is a predominant cause of NASH, NASH. So that should be considered. These people should avoid high sugar diets or high fructose diet and should avoid getting into obesity. None of the drugs is safe going to have effect on fibrosis in a pediatric setting. Next slide, please. Bariatric surgery is recommended in people who are unable to reduce weight by conventional methods, which improves all histological lesions, including fibrosis. Liver transplantation is an accepted procedure for NAFLD-related end-stage liver disease. The overall survival is comparable to other indications despite high cardiovascular mortality. And these people who have NAFLD, liver failure, and HCC, hepatocellular carcinoma, should be a candidate for liver transplantation. Thank you. Thank you for listening. If you have any questions or something, I'll be very happy to answer them.
Thank you so much, sir. Thank you for your such wonderful insights on the PPT that you have shared and making our viewers understand about the topic in
Hello?
such a better manner. Hello?
Are you able to hear?
Yeah, I can hear you. Can you hear me, sir? Hello?
Hello?
Sir, you are audible. Am I audible to you? Hello? Hello? Hello?
Hello?
Hello? Sir, I can hear you. Can you hear me? Hello? Hello? Hello?
Hello? Can you hear me?
I can hear you, sir. Can you hear me? Okay, I think there's some network connectivity issue. So we will just wait for sir to join in, and once sir is here, then we should start with the question answers. Hello? Sir, are you there? Hello? Hello?
Hello. It's okay?
Hello, sir, am I audible?
Yeah, now you're audible.
Yeah. You can turn on your camera, sir.
Okay.
Yeah, so I was talking about the insights that you have shared, sir, with us. So thank you so much for sharing such wonderful insights with us on our platform. We have received few questions from the participants. So with all your due permission, I would like to put across those questions to you. So the first question is related to the current guidelines. So what are the current guidelines for pharmacological management of NAFLD, including indications, efficacy, and safety profiles of available treatments?
Hello.
Hello, sir, am I audible?
Yeah. Very much. Yeah.
Yeah, so the first question is related to the current guidelines. So what are the current guidelines for pharmacological management of NAFLD, including indications, efficacy, and safety profiles of available treatments?
Okay. If the FIB score is less than 0.4, there is no need for any medical therapy. Lifestyle modification, weight loss, exercise 30 minutes a day, five times a week is enough. If the patient is on advanced fibrosis, we can put them on medicine. One is the PPAR agonist if the patient is diabetic, or a PPR alpha gamma agonist like saroglitazar can be used in patients with diabetic or non-diabetic in advanced fibrosis. None of the other drugs are recommended right at this time. Still, we continue with the weight loss of 10%, activity 5 days a week, 30 minutes, aerobic with lifestyle modification. Saroglitazar is only approved drug for use in advanced fibrosis for 6 months to 1 year therapy.
Thank you so much, sir. Thank you for answering that question. We will move to the next question that we have received, and the next question is related to the role of genetic predisposition. So, what is the role of genetic predisposition in NAFLD development, and how
There
does
are
it
two, there are two genetic variations. One is the PPAL3 genetic polymorphism, but that is quite rare. It is less than 1% of NAFLD that we see in the community. It usually is a very important factor in pediatric NAFLD or lean NASH. So these are the people who have highly resistant metabolic disease, highly resistant fatty liver, and rapid progression of cirrhosis. Little that we can do in controlling the progression of liver disease in these people. And when identified early, we can put them on PPR, gamma, and alpha agonists like saroglitazar, along with triglyceride lowering drugs like statins or fibrates, as well as lifestyle modifications. If the patient is found in advanced liver disease or cirrhosis, we can offer them liver transplantation as a curative option for these people.
Thank you so much. So thank you for answering that question. We will take the next question, and the next question is related to the lifestyle interventions. So, what lifestyle interventions have shown the most promising results in managing NAFLD, and how can they be effectively implemented in clinical practice?
Yeah, it requires little bit of support, more self-motivation, family support, as well as the community and the government support. So we need to concentrate on the diet. We have to reduce the calorie intake by at least 1,000 calories a day, and ideal to switch over to low calorie, low fat diet. So that is the best thing. Second thing is exercise in forms of anaerobic rather than resistant training. So 30 minutes exercise for 5 days a week. And third thing is these people should be monitored for progression of metabolic parameters like control of hypertension, control of diabetes, control of triglycerides, control of hypothyroidism, etc. So when these three combine, we can make sure that these people will not progress to advanced form of fibrosis.
Thank you so much, sir. Thank you for answering that question. Last question before we conclude, and the question is related to the most recent advancements in imaging technique for diagnosing and monitoring NAFLD progression.
Yeah. So the easy to pick up fatty liver is ultrasonogram, but it's less specific. So we rely upon fibroscan. Fibroscan is an excellent procedure to detect fibrosis in these patients. So we can do a fibroscan, which is very simple. Anybody can do that. So FibroScan is the best screening tool for diagnosis of advanced fibrosis. MRI, we reserve MRI for people who have a confusion in FibroScan scores, or people who have congestive heart failure, or viral hepatitis associated with that, or hepatocellular carcinoma. Those people, we subject them for MRI PDF. So non-invasive testing has become a cornerstone nowadays. We usually rely upon the FIB score. FIB score is available on internet. You can just input few of the parameters and get the FIB score. It can be done in a nursing station as well. So one is FibroScan, second is FIB score, with which we can categorize them into low risk and high risk. In high risk, we give them complete attention and support and medications. Low risk, we can monitor them.
Thank you so much, sir. Thank you for answering that question and all the other questions along with that. Thank you for answering them. I would like to thank all our viewers for their ardent participation that they have shown by staying tuned with us throughout the session. And I would like to thank you, sir, for taking out your valuable
Thank you.
time and
Thank
for
you.
being here
Thank you.
and sharing such
We'll meet with
wonderful
some other
insights.
important topic sometime later. Okay.
Sure,
Thank you.
sure, sir. Thank you so much, sir.
Happy evening. Thank you. Bye.
Bye, sir.